Good evening and welcome to the University of Melbourne and this ICT for Life Sciences Forum presentation. My name is Luan Ismail. I'm the Executive Director of the ICT for Life Sciences Forum, and it's my very great pleasure to welcome you here this evening. The ICT for Life Sciences Forum celebrated its 5th birthday last month. Today our mission remains unchanged from that developed 5 years ago, to communicate the exciting developments taking place at the convergence between the physical and life sciences, which is propelling new knowledge, ideas and innovation that are tackling some of the most ambitious challenges in medicine. And we also wanted to encourage knowledge sharing and collaboration between researchers working at the interface, and also to inform the wider community about the exciting developments taking place at this interface in Melbourne and around the world. For those of you who have been on this journey with us for all or most of the past 5 years, thank you for your support and interest in being a member of this important community. And for those of you who have joined us recently, welcome, and we look forward to serving up many more informative and inspirational talks and providing the opportunity to meet some of the brightest thinkers and doers we can bring you. As the ICT for Life Sciences Forum begins its 6th year this evening, we're pleased to bring you a leader in their field who is passionate about delivering better health to the community. Professor Ingrid Winship is the Executive Director of Research for Melbourne Health and the Chair of Adult Clinical Genetics at the University of Melbourne. A medical graduate from the University of Cape Town, she completed postgraduate training in genetics and dermatology, and in 1994 Professor Winship took up the academic position at the University of Auckland and later became Professor of Clinical Genetics and Associate Dean for Research in the Faculty of Medicine and Health Sciences. Professor Winship is a member and immediate past chair of the Bio21 Victorian Hospital Directors Forum and a member of the Bio21 Scientific Advisory Council. She's a member of the Victorian Cancer Agency, the National Health and Medical Research Council Human Genetic Advisory Committee, and the Victorian Life Sciences Computation Initiative Steering Committee. She serves on the board of the Walter and Eliza Hall Institute and the Peter Doherty Institute Council. She's a member of the Executive Committee of the Cancer Council of Victoria's Clinical Network Executive Committee. Please welcome Professor Ingrid Winship to deliver a presentation using genetics to save lives, informing us how genetics is being used today in a clinical sense. Ingrid.
Thank you.
Thank you. Thank you.
Thank you very much, Luan, for the invitation and for that lovely introduction. And I will apologise at the beginning for a rather pretentious title to my talk. My more conventional clinical colleagues tend to tease me when I say I'm going to save lives, because they don't have an image of a clinical geneticist running around with a crash cart. And I haven't had a speaking part yet in ER, but I'm still waiting. But we really do use genetics to save lives. And as we move from genetics, the single gene, to genomics, multiple genes, it becomes more important. So I suppose to start with, everything that we do in a clinical sense needs to acknowledge all the work that starts right at the very beginning, the concept, the basic science, the discovery, and then the translational steps that take us from a concept through discovery in a continuous pattern to better clinical outcomes, and then in the clinic go back to informing those basic science questions that we need to answer. And without medical research, without the convergence of all these great minds, we would still be using foxgloves and leeches in order to treat our patients. So about 165 years ago, this year is the 165th birthday of the Royal Melbourne Hospital, where I work down the road. And around the same time as people were starting to treat patients without genetics, Gregor Mendel was playing with his sweet peas, working out the rules of heredity, the particles of heredity, which he named genes. And this year, 2013, sees three very important anniversaries. We're all aware of the double helix of DNA and of Watson and Crick, a duo, who described this double helix in 1953. And I think most people acknowledge the 10 years since the Human Genome Project was first described by Francis Collins and Craig Venter. What a lot of people don't recognize is that 10 years ago, UNESCO also published their Declaration of Human Rights, the Universal Declaration of Human Rights, for the treatment of human genes and for genomic information. And so that human side is important alongside all the scientific discovery. So to this audience, I'm sure that you all know that genes are bundled up into chromosomes and inherited at a rate of 50-50 from parents, and that DNA is the alphabet of life in A's and T's and G's and C's. And the extent of testing has come a long way over time, where we could look at whole chromosomes from about 1956 through different methods that could pick up changes in rearrangements of chromosome to what has been the gold standard of sequencing, walking up and down the ladder of DNA in order to see if there are changes in a gene which may have significance. And now, of course, with new technology, we can look at the whole lot in one go. So we've gone from looking at a chunk to a tiny piece to a whole lot of tiny pieces, and the information now generated is mind-blowing. A lot of people ask what the difference is between genetics and genomics, and I think to many it's not entirely clear. But genetics really is the study of heredity looking at one gene at a time, as opposed to the genomics, which is all the genes and all the interactions that interact to grow, to differentiate, and for the body to function. And so it's important to know the distinction and to know that in using genetics, we must use genetic and genomic technology. And it's all about difference. So if you read the popular press, you'll know how close you are genetically to a fruit fly, a chimpanzee, a tomato. But it's those variations that make us unique, and also variations that make us prone to certain illnesses, and that's where clinical geneticists come in, particularly in the world of adult medicine, where we try to predict what your risks are and then manage that risk for better health. So you can use genomic DNA in many ways. You can confirm a diagnosis that is already clinically evident. Probably more important is being able to predict risk. So you can confirm a diagnosis within a family and then work out who else is at risk so that you can pre-symptomatically alter the path of that disease as much as is practicable. The far end of this kind of prediction is in assessment of unborn children, and particularly unconceived embryos. And then some interventions. Pharmacogenomics offers a lot of promise. Gene therapy offered a lot of promise, but hasn't delivered a lot. As a physician, as somebody who works with adults, people immediately say to me in social circles, but surely you're a pediatrician if you work in genetics. Isn't that the target age group? And my response is, you're an adult for 4 times as long as you're a child. So we really do have to think about the genetics of 4/5 of your life rather than only your childhood. But really there's no target age group. Somebody tried to suggest that we were a service that used research to provide answers from the cradle to the grave. And that's also not correct, because we work long before the cradle and well after the grave. A lot of the work we do is preconceptual, and sadly, a lot of the work we do is with the coroner, where we are referred patients for sudden cardiac death, and we perform what's called a molecular autopsy in order to try and answer questions after death. So how does it all work? Well, it's really quite simple. Half comes from mum, half comes from dad, and the rest is history. So in trying to bring the technology into an everyday patient environment, we can do 2 things. One is we can manage the patient who comes through the door, who is ill, who has a problem, who seeks advice about how they can improve their health and how they can take the best options. And this includes a lot of diagnostic work. Often there is a constellation of features that fit together, not necessarily all in the same body system, that alert us to a diagnosis that it's likely to be a genetic syndrome rather than a lot of different problems. We can alter the management of individuals. We can alter their ongoing risk management. Once you've had some sort of health problem, you're often more prone to the same thing again or other different comorbidities. So looking at a holistic model does need the understanding of the genome. And one of the most important things, and I'm glad to see so many genetic counselling students here tonight, is counselling and advocacy is an absolutely pivotal part of everything that we do. But it's not only the patient. The difference between a clinical geneticist or a genetic counsellor and any other kind of health professional is we don't ever see the individual sitting in the chair as an isolated person. They're a person standing in front of a nuclear family, an extended family, sometimes a dynasty of people who may also need management. So family management is a really important part of what we do. And this comes down to two things. What is the risk? Assessing the risk, and the genetic testing is the most accurate way of assessing the risk. And then how do you manage that risk? What can you do in order to tell the person who you've just told us at high risk that they can manage their risk? Because as you can imagine, telling somebody that they have a high risk for something for which they have inherited a gene can be extremely stressful. So managing that risk is a very important component. And this takes a team. None of us work alone, and I feel very privileged to work in a team with very skilled individuals, a lot of different kind of health professionals. It really is, as Luan mentioned, convergence of people with different skill sets, whether they're counsellors, diagnosticians, whether they're the data staff who verify all the information, because people notoriously report their family histories in an inaccurate way. And so verifying, before you make decisions, you need to verify that the data is indeed correct. And so there's a lot of background work. It takes about 15 hours of human time to get a family worked up so that they can be seen in a clinic. And we've got core staff who only work in genetics, and then content people who come from far and wide to put that content expertise that helps the surveillance, whether it's a medical oncologist or a cardiologist, to give us the advice on the most up-to-date way of managing those problems. Somebody described this slide as spaghetti and meatballs, and it does look a little like that. But the point is to say that no branch of healthcare can claim genetics as its own, or conversely, all branches of healthcare should claim genetics as its own, because there is no component of the human body that doesn't have genetic control, and there are no patterns of disease that do not have some level of heritability. Some are greater, some are lesser, but whether you're talking about a kidney, a white blood cell, or the skin, genetics plays a role. So kidney disease is something that people don't immediately think about. And polycystic kidney disease is probably the commonest form of inherited kidney disease, where people end up in kidney failure and on renal replacement therapy. Earlier this week, I was talking to one of my renal colleagues about a study she's doing on X-linked Allport syndrome. And when we get to thinking about saving lives, this is a staggering fact, but published last year was a study that showed that if you identify males who are at risk of X-linked Allport syndrome, in other words, young men who have the gene that says, as an adult, you will develop this kind of renal failure. If you start those young men on ACE inhibitors, easy, accessible, cheap, PBS-listed drugs, you will slow down the onset of renal failure by 13 years. That means that you won't need dialysis for 13 years on average, which is a long time. If you think about the statistics of dialysis, age-matched individuals are 10 times more likely to die if they're on dialysis than if they're an age-matched control. So keeping people from renal failure and off needing dialysis is an enormous contribution to healthcare. And if you look at people who are having dialysis, renal replacement therapy such as transplantation, 40% of children and 20% of adults on dialysis have an inherited reason for their kidney failure. Likewise, cardiac genetics. Now, you could argue that much ischemic heart disease is on the basis of an inherited predisposition to hypercholesterolemia, and there certainly are people who have heart disease very young, teenagers, people of 20 and 30 having exceedingly high cholesterols because of their genetic predisposition. But there's a whole group of channelopathies, so calcium and potassium channel deficiencies, cardiomyopathies and aortopathies that are single gene disorders with variable levels of penetrance expression in individuals, the severe effects of which can often be risk stratified and therefore mitigated. So in the long QT syndrome, and I mentioned before that the coroner is a frequent referrer of patients to our clinic. Well, it's not actually the coroner, but it's the pathologists. So when a young individual dies and no obvious cause is found, it's what's called an unascertained death. And when this happens, the coroner or the team at the coroner's office will refer that family to us for investigation to see why that ostensibly healthy person died, often playing sport or often in sleep. And we're able to investigate families in this way. And there are two questions that people always ask. Why did my young person die? And what are you going to do to make sure that the rest of the family doesn't, what about how you're going to protect the other kids too? And by putting people through physical testing, exercise testing, cardiovascular testing, as well as the molecular autopsy, and here you can see a mutation in long QT1, the KCNQ1 gene, in the 5th exon, a change from T to A changes the valine to methionine, and this little change in this little gene has caused a person of under 20 to die playing football. And this is a tragedy and really needs to be prevented. And so once we identify this kind of problem in a family, we're able to go back. These are dominantly inherited genes, so generally one of the parents carries that gene mutation. We're able to go back and assess parents and siblings and children and future children in order to put a safety net in place, give a medication, put a defibrillator in place so that nobody else in that family dies as a result of the long QT. Even more vexatious is the fact that many antidepressants actually prolong the QT interval, and prolongation of the QT interval in these people causes arrhythmias that make the heart beat out of kilter, and this is the cause of death. So if you have an individual who's already got a longish QT and you give them an antidepressant because quite reasonably they need it, they've had a loss in the family, it may actually make it worse. So this is really important. I don't know that I'd like to make a diagnosis of this gentleman, who's well known to most of you, but he has a very typically long linear body habitus. And this can be a clue with the long fingers, the long-limbed, tall stature of the Marfan syndrome. And this is emblematic of one of the group of aortopathies. So in the Marfan syndrome, being tall and slender isn't of itself a problem, but there are more serious consequences such as dislocation of the lens of the eye, and more severe is dilatation of the aorta. The great vessel that takes blood around the body becomes weak, and as the heart beats and beats on that vulnerable stretch of aorta, it's liable to dilate, to get bigger, and to rupture. And to me, it's an absolute tragedy to hear that we are still having referrals of people with Marfan syndrome from the coroner, that they're not being picked up earlier, because they can be recognized diagnostically, and there are now a whole panel of genes that predispose to aortopathies that we can use in families in order to monitor, to give medications, evidence-based strategy using losartan to reduce the pressure of the blood beating against that aortic wall. And if people's aortas are dilating, timely surgery is curative. Emergency surgery is not. So these are strategies that really are predicated on good genetic data. This is a beautiful B cell, and many, many, many immune deficiencies are on the basis of single gene disorders. This is a picture of the CFB gene, and I'm very proud to say that our registrar, Charlotte Slade, published this particular picture, which I haven't referenced here, in this week's New England Journal of Medicine, in a very nice collaboration, found a young woman who had intractable infections, never seemed to get better despite care, found that she's actually deficient from her mother and from her father, 2 mutations, an autosomal recessive predisposition to infections, and we now know that the CFB gene is the problem in this B cell deficiency. And we're able to go back to her family and give them prophylactic antibiotics. Had she had the antibiotics she needed, if you have an immune deficiency and you have meningitis many times, ultimately the worst case scenario is obviously death, but brain damage, limitation of intellectual function is a very sad outcome for entirely preventable disease. And so by identifying early in the piece when people are predisposed to these infections that they can't control, we're able to put them onto antibiotics, to use vaccination, and to prevent people from getting infection. And on the strength of the collaboration, have just set up a really nice collaboration with the Walter and Liza Hall Institute, where we'll be doing more studies of immune function in people. The space I mainly work in is in the predisposition to cancer. So how do you know that small but important slice of the pie that is the genetic predisposition to cancer? And this is an area that we really can make a difference. If we recognize that across families, if you've got a lot of people with the same sort of thing or a cluster of things, constellations of tumors, so we know that breast and ovarian cancer go together, endometrial and bowel cancer go together. Learning those constellations, looking at other features like collapsed lungs, skin lesions, and kidney cancers, takes us to a diagnosis where we can then treat optimally that individual plus manage their family for risk. And as we get better at this, recognizing the tumor will be even more important, because one day when we've screened people so well that there's no family history of cancer, we will have to rely on genetic tests to tell us who's at risk. So hereditary breast cancer, and there's a whole conference going on today about hereditary breast cancer, has a very high heritable component. And there are a number of genes that we know a lot about, BRCA1 and 2. There are a lot of genes that we know quite a lot about but haven't got clinical utility yet. And there are a lot of very elusive areas that we haven't explained yet. But it's really very important because breast cancer is common. And if we can find out who has an increased predisposition, we can rationally look after those people. At the moment, everybody who's 50 goes into breast screen, and that's a marvelous system. But what about all the young people who are at risk, who aren't getting anything? If you have a BRCA1 or 2 gene, this is the steeply rising risk of breast cancer and ovarian cancer, and not quite as bad, but still an increased risk of BRCA2. Angelina Jolie has certainly given us a very good advertising campaign for our clinic. I think some of our staff are exhausted because we've had more, something like 5 times more people phoning to ask about BRCA testing in the last couple of months, and it shows the power of marketing. But what's also important is not only family history, but recognizing tumor characteristics. And if you take young women and interrogate that tumor, you will learn as much about the risk of an inherited component as you will in taking family history. So we have to use all the collateral information that we can get, and histology will never go out of fashion. But what you can do is you can optimally screen, and here you see the tumor, with MRI. So the highest risk women need MRI. Mammography is probably not as good. The highest risk women also need more cancer surveillance from a younger age. Those with mutations are advised on an evidence-based strategy to have their ovaries removed. Now this sounds quite radical, but having one's ovaries removed before menopause is life-saving. It reduces the risk of breast cancer by 50% and also reduces the risk of ovarian cancer substantially, which is a later onset risk. And if people are unfortunate enough to develop breast cancer, then targeted therapy, looking at the PARP inhibitor range of medications, can be better. Probably what's equally important is that on average, given their dominant genes, 50-50 chance that if you're in a family with a BRCA1 mutation, you may not have inherited it. So being able to release people from screening if they don't need it is also pivotal, because if you can actually walk away knowing that you have not inherited that gene, you have not inherited the family risk, is a very reassuring state of mind. Lynch syndrome, which used to be called hereditary non-polyposis colorectal cancer, is now named to honor Henry Lynch, who described it. One of the bad reasons of HNPCC was it focused too much on colorectal cancer. And probably the most important message about Lynch syndrome is that it is not only a colon cancer syndrome, but it's a multi-system syndrome. And new evidence, and Ong Win is sitting up the back somewhere, published recently the fact that there are many, many more cancer types seen with these mismatch repair genes, including breast cancer. And so we have to think about the overlap of syndromes and the convergence of information so that we get this right. Now this is just a graph of the risk depending on the 4 different genes, but lifetime cumulative risks of colorectal cancer are high, and therefore these people need high-risk surveillance. We used to diagnose Lynch syndrome on the basis of Amsterdam criteria, which were entirely clinical, the number of people affected and ages. Then it was Bethesda when we cottoned on to microsatellite instability and immunohistochemistry. And now, after Melissa Southey's paper in 2005 talking about immunohistochemistry, we now use the Melbourne criteria. And this is using immunostaining as a pre-test. It's a phenotypic test that we do at the moment in Victoria on all people under the age of 50 who have colorectal cancer. In Perth, they use the same sort of testing on all people under 60. In Auckland, we used the same 50-year-old cutoff. But there are now models looking at possibly even doing universal testing. This is a very easy test. And if you have loss of expression of one of these genes in the mismatch repair cascade, it may indicate that you've got a gene for Lynch syndrome, and not only will you optimize your therapy, but so will your family. When we look at families, we have to think also, when is a mutation pathogenic? All changes, as with these capsicums, all change is not pathogenic, all change is not disease-causing. And here is a very subtle, this is a case of Lynch syndrome, and a very subtle point mutation in an individual which might be quite difficult to interpret, as opposed to this MLPA analysis where the Manhattan graph should look quite even, and here you can see an enormous chunk. Many, many exons are deleted from this gene. Now that's an easy one to interpret, but if we're going to make clinical decisions that talk about doing different surgery, removing people's ovaries, giving them medications, we need to be absolutely certain that we've got it right. And this is where the translation of research into the clinic is so important. And programs like the Human Variome Project, which was born in Melbourne, an international project now, are so important for understanding human variation. Out of this research comes algorithms that we use in clinical care, which optimize treatment. And ultimately, if you know that a person with colon cancer has got Lynch syndrome, then you will not do a small resection of that tumor, but you will do either half the colon or optimally a subtotal colectomy take away as much of the bowel as you can, leaving good function, so that you don't put them at risk of the subsequent cancers, which we know people with mismatch repair genes are at risk of. So the penetrance of the gene, how likely the gene is to cause a problem, how likely you are with that gene change to get cancer, either the cancer you had in another part of the colon or a different cancer in that constellation, is important. Recently, the CAP2 study was published showing that aspirin is very good at protecting the bowel. So the polyps that are the precursor to the tumors are less likely to develop with aspirin therapy. And a study that was published in Gastroenterology showed a 15-year group who had annual colonoscopy, 133 people with genes, mutations in the mismatch repair genes, and none of them had died of colorectal cancer. I think that's saving lives. Most importantly, and I must pay credit to Mark Jenkins and his team, the risk of colon cancer is not a bell-shaped curve. We all think in sort of normal distributions of most things. Well, colon cancer risk is not a bell-shaped curve. Most people have very little risk, and a few people have a huge risk. So we need to use our genetic technologies to work out who those people are. Work done by Rosetta Stone at the University of Melbourne shows that 98% of Australians are actually at population risk, either really very low risk of colorectal cancer. Strangely, 8% of them are being overscreened. 2% of Australians are at a very high risk of colorectal cancer, and almost all of them are being underscreened. So put crudely, you could probably relate the number of colonoscopies done to the postcode more reasonably than to the cancer risk. We need to look at this because we're using enormous resources, thousands of colonoscopies being done to find cancers in the wrong people. And so we should be using these technologies led by genetics in order to test, to screen, and to treat the right people. To this end, we have a new Centre of Research Excellence through the University of Melbourne, which is a collaboration between the university, the hospital sector, the general practice sector, and most importantly, the model has come from the question, well, where do most of these colonoscopies happen? GPs don't do genetic tests, but they see most patients. So working together with general practitioners, working together with gastroenterologists, clinical geneticists, epidemiologists, statisticians, the whole team approach, a whole of system approach in order to try and reduce the burden of disease. A lot of people think traditionally about genetics as prenatal diagnosis and reproductive options. In the adult world where I work, it's extremely unusual for people to say there is a risk of an adult onset condition such as polycystic kidney disease or Alport's disease or colorectal cancer. It's very unusual for somebody to want to have a prenatal test and consider terminating a pregnancy on something that may happen or may not happen in adulthood. However, people do say that they're worried about their offspring living with the same fear of cancer, of heart disease, of the sort of things that they've lived with. So reproductive options do need to be considered. People vote with their feet, and they ask for what they want. And one of the things that many people at risk of adult onset genetic disorders are interested in is pre-implantation genetic diagnosis. This is an alternative to any kind of prenatal test where a couple can have their own egg and sperm through a process called ICSI, where the sperm is actually injected into the egg. This is a fertility treatment used for people who are not infertile. But what it's doing is ensuring that you create an embryo under controlled circumstances that you can then biopsy and take that one cell off to a lab who are very, very committed and labor intensive because they don't have long. That embryo is going to divide and divide and divide. It's not going to hang around while a lab takes a turnaround time or does a batch. So it has to be done very quickly. But what you can do with PGD is you can offer people the choice of embryos, potential babies, through IVF, that are free from the disease for which they're at risk. These are not designer babies. You can't make them tall or curly-haired or any other characteristic. I don't even know that you can choose whether they'll be girls or boys. All you can say is that they should be free from the disease for which they are at risk. Pharmacogenomics is probably the most trendy way of thinking about genomic data at the moment. Millions of people swallow millions of pills every day. And if you look at aged mental health, your average elderly person who's got a little bit of high blood pressure, a little bit of diabetes, a little bit of memory loss, a little bit of this and that, is taking so many pills that heaven knows what sort of biological warfare goes on in their gut. Some of those pills work. Some of those pills probably do nothing at all, which is maybe just as well. And sometimes they cause side effects. So what we need to be smarter about is understanding the genome of the individual so that we can give them the right pill every time. Now, there's a very serious complication called Stevens-Johnson syndrome, which is essentially like having third-degree burns of your whole body, which can be caused by something very simple, one pill. So, for instance, carbamazepine is a wonderful drug for epilepsy, and it's about 50 cents a dose. But some people get this horrible reaction. So, in response, neurologists will then say, well, we can't use this drug anymore, so we'll use something that costs $50. Well, that's unsustainable, because only a few people, and you can now tell that if they've got this particular HLA type, they will be at risk of that reaction, and everybody else will be fine. So in China now, if you are going to go on to carbamazepine, you have this test before you do it. The same applies to an antiretroviral, abacavir, a gout treatment, allopurinol. These are all genetic predispositions to the drug response rather than the disease. And if we wish to get the right drug for the right person every time, what I would like to do is what's called preemptive pharmacogenomics, and something that's in my master plan. And that is that everybody who goes through the hospital door or through your own electronic health record, through your GP, you have a pharmacogenomic analysis of all the things that you're at risk of. Because when you come through the emergency room door, there isn't time to do a genetic test. Unfortunately, we're not as good as CSI. We can't turn them around in 5 minutes. So when I asked my cardiologist husband if he would like a genetic test for clopidogrel before they do a cardiac procedure, he says, can you give me the result before I've prepped for theatre? Well, I can't. But if we do preemptive pharmacogenomics, we would know that when Mrs. Jones comes in through the ED with her chest pain and is on the way to have her stent, what will be the best drug to give her to fix that problem? So how much can you know and how much do you want to know? Well, information can be very empowering. You can make your health decisions, you can make your lifestyle choices. If you know that you're not going to live to a very old age, you can go traveling instead of work. But we have to think about all of these impacts, because the first premise of everything we do in healthcare is do no harm. And we don't want to use genetics in order to have preventive strategies and then make people sick with fear. So we do have to think about all of the so-called LC, the ethical, the legal, the social, spiritual, and I would add cultural impact. DNA in some cultures is not autonomous, it's collectively owned, and we need to be cognizant that the cultural mores are important in the use and utility of genetics. This is a slide I nicked from my son's school project. If Frankenstein had considered more about the impact of what he was doing, he may not have had a monster, he may have had an Adonis. And so this is what we want to do. So as we move from gene by gene testing, and already we're moving away from doing one gene at a time to panels of genes, to whole exome or whole genome sequencing, we raise a lot of new issues. It offers huge promise, because currently, even in the best of clinical scenarios, our current testing has a fairly poor diagnostic yield. About 20% of women we test for BRCA1 and 2 mutations will get an answer, so 80% will not. Heterogeneity is the watchword. There are many genes that cause problems. Syndromes overlap. Testing one gene at a time is expensive, so if we had a mechanism to do lots at the same time, it makes sense. And I put this slide together to show that one gene, lamin A-C complex, has many, many functions, and one phenotype, a pheochromocytoma, a tumor of the adrenal gland, has a growing list of single genes that can cause a predisposition. So we can't be reductionist. And the more exome data we can get, the more informatic help we will need to interpret it. Of course, when we look at the whole genome, we're going to find out much more than we were looking for. And this is where we have to work as a team. That in a project that we've recently designed, we're filtering the information so that we only get genes in this particular project that are manageable, that we already know their penetrance, how likely they are to cause a problem, their utility, what can be done, and we have strategies to work with. There's a very insightful paper from Moin Khoury's group in the US that talks about binning results. So this bin is for medically actionable, important things that you need to know to keep you well, even if that wasn't what you were looking for. This bin is maybe informative, and this bin is, well, we really don't know and really shouldn't be talked about. But in the first bin, if it's medically actionable, if there is a way that you can, if you inadvertently find a gene, for instance, for sudden cardiac death when you're looking for breast cancer, then it's really important that that family has the opportunity to consider taking interventional steps to protect them from the other condition that we found without really looking for it. And that begs the question of consent, because people need to know right from the beginning that we may find answers that they weren't looking for. I love this picture. I use it in my lecture to the students on genetics and art. And you might say, what's the interface between genetics and art? But it's huge. There are many depictions of genetic syndromes through the centuries in different artistic catalogues. There are many artists who have genetic disorders themselves, like Toulouse-Lautrec. But there is a whole new genre of art that's been inspired by genetics and genomics. And this piece by Gil Karan is called Cosmic Cacophony. Now, although it's a sensational piece of art, I don't think cacophony is a word that I like to think about when I'm running a clinical service. So we go back to the more conventional translational research and back into clinical practice. I'd like to think that we've probably reached the point of the Rosetta Stone. We've generated a lot of information, and we're very lucky to have the VLSCI on campus that offers us computational opportunities, and people like Terry Speed, who's been honoured recently, I think would be regarded as one of the finest scientists in the country, who has a pipeline of people learning bioinformatics so that we can interpret the hieroglyphics that the laboratory scientists are providing. I'll leave you with the idea that personalized medicine is not necessarily personal. It may be family, it may be community, but it certainly has a preventive aspect. And what we're trying to do through genetics and genomics is early detection, pick up problems before they're a problem, do things quickly, target your therapy, understand the pathway, use the right drug, prevent predictable disease and predictable complications of those diseases. So recognizing that if somebody has one problem, they may be at risk of another. And preventing predictable complications of treatment, where we as practitioners may add to people's health problems by not giving them the right drug. So I hope I've given you a small taste of using genetics to save lives. Thank you.
In closing, I'd like to thank the forum sponsors, without whose generosity we wouldn't have the pleasure of having Ingrid here this evening. Melbourne Health is a sponsor. Thank you, Ingrid. Phillips Ormond Fitzpatrick, IBM, the Melbourne Convention Bureau, Melbourne School of Engineering, RMIT University, Monash University, Victorian Life Science Computation Initiative, the Bionics Institute, the Centre for Neural Engineering, Bionic Vision Australia, the CSIRO, the Australian Nuclear Science Technology Organisation, the Victoria Research Laboratory of NICTA. Please join with me in thanking Ingrid for her presentation. Thank you and good evening. Thank you.